Hand, foot, and mouth disease, HFND, is an acute viral illness characterized by vesicular eruptions in the mouth and papillopsicular lesions of the distal limbs. It is not to be confused with foot and mouth disease of animals, which is caused by a different virus. HFND is usually mild and self-limiting. The incubation period is 3-7 days. The mucocutaneous lesions appear 1-2 days after a prodromal period of fever, malaise, and myalgia, and last approximately 7-10 days with spontaneous resolution. HFMD is caused by enteroviruses from the picornavirus family, small, non-enveloped, single-stranded RNA viruses. The main enterovirus serotypes responsible for HFMD are the Coxsackie viruses. In Europe and the US, HFMD is most commonly associated with group A Coxsackie viruses. Coxsackie A16 is the most common cause, although outbreaks have been associated with the A6 and A10 strains. The Coxsackie virus A6 strain causes an atypical HFMD, with a more widespread and extensive skin disease, nail shedding, and higher risk for adult infection. Group B Coxsackie viruses may also be causative. Less commonly, but more seriously, HFMD can be caused by enterovirus 71, EV71, which has caused epidemics in East and Southeast Asian countries. Hand, foot, and mouth disease, HFMD, is spread by direct contact with the nasal and throat secretions of an infected person, for example via coughing and sneezing, direct contact with fluid from the blisters, fecal-oral transmission. This can also occur from infected people who are asymptomatic but who may still excrete the virus in their faces. Vertical spread from mother to fetus can occur. It is transmittable immediately before and during the acute stage of illness, and for longer in some people, due to its presence in faces. Fecal shedding can persist for approximately 4-8 weeks after the onset of illness. HFMD is not transmitted to or from animals. It is not related to foot and mouth disease of animals. Complications and prognosis of HFMD. Complications of hand, foot, and mouth disease, HFMD, are rare. Dehydration is the most common complication due to oral pain causing reduced fluid intake. Secondary bacterial infection of lesions is rare, but can occur. HFMD caused by the enterovirus 71, F71 strain is associated with rare serious, life-threatening neurological sequelae such as brainstem encephalitis, aseptic meningitis, acute flaccid paralysis, and autonomic dysregulation, leading to pulmonary edema and myocardial impairment. The mortality rate in complicated cases is cited as 10 to 25.7%. Case reports have described miscarriage, stillbirth, congenital malformation, intrauterine growth restriction, and hydrops fetalis following HFMD in pregnancy. However, causality is not proven, and a small retrospective cohort study of pregnant women with HFMD, N53, reported rates of miscarriage and congenital malformation within expected background rates. The World Health Organization and NHS state that there is no clear evidence of fetal risk. HFMD acquired around the time of delivery can lead to neonatal infection. This is mostly mild and self-limiting, however. Neonatal complications, including severe hepatic, respiratory, and neurological disease, have been documented. Reassuringly, none of these appear to have been associated with the most common Coxsackie A16 strain. The prognosis of hand, foot, and mouth disease, HFMD, is generally excellent as it is most commonly a self-limiting disease. HFMD caused by Coxsackie A16 is a mild disease, and the vast majority of people fully recover. Oral and skin lesions nearly always fully resolve without treatment in 7 to 10 days. HFMD caused by Coxsackie A6 is also generally self-limiting, but the acute phase may be followed by desquamation of the palms and soles for several weeks, and onychomadesis, shedding of the nails, within 3 to 8 weeks of symptom onset. HFMD caused by enterovirus 71 has a higher incidence of neurological involvement, such as aseptic meningitis and encephalitis. Although this remains rare, infection results in immunity to the specific causative virus, but recurrence of HFMD can occur with a different member of the enterovirus group. The diagnosis of hand, foot, and mouth disease, HFMD, is usually clinical, based on typical symptoms and signs. HFMD typically presents as a mild illness with sore throat, with or without a low-grade fever, tender lesions in the mouth, enanthem, and/or a rash on the body, exanthem. Ask about the presence of prodromal symptoms. The prodromal period may last 12 to 36 hours. Early symptoms are fever, typically 38-39 centigrade, malaise, loss of appetite, cough, abdominal pain, and sore mouth. Rarely, vomiting occurs if HFMD is caused by enterovirus 71. Examine the mouth for characteristic features. Scattered ulcerative lesions of the oral cavity occur within 1 to 2 days. Typically, they begin as 2 to 8 millimeter erythematous macules and papules and appear most commonly on the hard palate, tongue, and buccal mucosa, but also on the lips and pharynx. Lesions progress rapidly to vesicles, which readily erode, leaving shallow yellow-gray ulcers surrounded by an erythematous halo. In severe cases, the lesions may coalesce, leaving the tongue red and oedematous. Examine the rash for characteristic features. Macules and papules of the hands and feet usually soon follow the oral lesions. Typically, they are 2 to 5 millimeter sparse erythematous macules and papules, often with a central grayish vesicle. The sides of the fingers, dorsum of the hands, and margins of the heels are more frequently affected than the palms or the soles. Lesions are frequently elliptical, with the long axis running parallel to the skin lines. The buttocks and groin area may also be affected. Lesions may be asymptomatic or painful. HFND caused by Coxsackie virus A6 may present with a more widespread rash that extends beyond the palms and soles, and may preferentially occur in areas prone to atopic dermatitis, the antecubital and popliteal fossae. Petechiae and severe blistering may be observed. There may be subsequent skin peeling and/or nail shedding. Laboratory investigations, such as oral, skin, or rectal swabs, are not usually necessary in primary care owing to the self-limiting nature of the illness. It may be difficult to differentiate viral illness from more serious causes of fever and rash in young children. Conditions that may resemble hand, foot, and mouth disease, HFMD, include herpes angina is caused by Coxsackie of viruses including A16, which presents with high fever, malaise, headache, and oral lesions, but has no associated exanthema. Rash. Herpes stomatitis, common in children and in immunocompromised people. Aphthous ulcers can become herpetiform and lead to stomatitis. Chickenpox, suggested by very itchy rash, mainly limited to trunk and extremities. Erythema multiforme Stevens-Johnson syndrome typically presents with target lesions on palms, soles, and distal limbs. Vesicles coalesce and ulcerate, and mucous membrane involvement can progress to life-threatening Stevens-Johnson syndrome. Viral pharyngitis. Kawasaki disease, a systemic vasculitis that primarily affects infants and young children. It causes fever, conjunctivitis, strawberry tongue, peeling skin, polymorphous rash, and cervical lymphadenopathy. Rare complications include coronary artery dilatation and aneurysm formation. Pompholyx eczema, blisters may develop on hands and feet. Lichen planus, may present in the mouth with painful erosive lesions, Wickman striae. Traumatic ulcers, such as from ill-fitting dentures, thermal trauma, or buccal aspirin. Gingivitis. Behçet's disease, typically recurrent aphthous stomatitis with genital ulceration, eye involvement, and skin lesions. Pemphigus vulgaris or oral bullous pemphigoid. Painful mouth ulcers are present, and skin lesions are usually evident elsewhere. Management of HFMD arrange urgent hospital admission if there are symptoms or signs of central nervous system involvement, such as persistent or severe headache or fever. Myoclonus with sleep disturbances, confusion, weakness, lethargy, drowsiness, irritability, generalized seizures, and coma may suggest encephalitis. Where features are typical, reassure the person, parent, or guardian that hand, foot, and mouth disease is usually a mild, self-limiting illness. Advise on self-care measures. Ensure fluid intake is adequate. Young children are particularly prone to dehydration. Inadequate fluid intake leads to signs such as reduced urine output, lethargy, cold peripheries, and reduced skin turgor. Consider admission to hospital if there are signs of significant dehydration. Advise that a soft diet may be necessary if mouth ulcers are painful, and that foods that are hot, spicy, salty, or acidic may cause oral pain. Consider advising use of paracetamol or ibuprofen if required to reduce fever and pain. Advise on measures to reduce the risk of transmission. Do not prescribe antibiotics either orally or topically unless secondary infection is suspected. Do not prescribe antiviral medication. Follow-up is not routinely required, but advise the person to seek medical advice if they become dehydrated or more unwell, or if oral ulcers persist for more than 3 weeks. If oral ulcers are persistent, use clinical judgment to determine whether to refer using the 2-week wait pathway. Measures to reduce the risk of transmission. Advise the person on general hygiene measures to reduce the risk of transmission. Ensure that hands are washed and dried thoroughly after using the toilet and before eating. Ensure the mouth and nose are covered when coughing and sneezing. The nose and mouth should be wiped with disposable tissues, and then hands washed. Particular care should be taken when handling nappies and tissues. Soiled clothes, bedding, and towels should be washed on a hot cycle of the washing machine. Cups, eating utensils, towels, and clothing should not be shared. Water should not be deliberately used, as the fluid is infectious. Children do not need to be excluded from nursery, childcare, or school for infection control purposes. The child should not attend nursery, childcare, or school if they are too unwell to attend. There is no need to isolate the child, for example, excluding visitors or household contacts, or investigate close contacts. Notification is not required in the UK. Contact the local Public Health England (PHE) centre if a large number of children are affected and an outbreak is suspected. Pregnant women should avoid close contact with any person with hand, foot, and mouth disease. Women who are pregnant and have suspected hand, foot, and mouth disease (HFMD), or who have had contact with a person with HFMD, should be generally managed as for non-pregnant women. However, consider seeking advice from an obstetrician if the woman is immunocompromised or is within 3 weeks of delivery, as investigations to confirm the diagnosis may be necessary. An observation of the neonate may be indicated